Dr. Simant Kumar has to leave because he's got a flight to catch. So we will be taking that next topic as practice changing news in neurology. Over to Dr. Simant Kumar Jha. He's a senior consultant in the Department of Critical Care Medicine, PSRI Hospital, New Delhi.
Pointer. Pointer is not there. So, I'm especially thankful to Pradeep Rangappa sir and Ajit Kumar sir for inviting me. And it's a difficult topic I have tried to cover. Starting with the drug Ernumab, you might have heard. It's not moving. Here. Pointer is not there. Ma'am. What's there? We can go from here now. Okay. So you can see the what is this drug Ernumab, what it does, what is the mechanism of action. Basically, this is calcitonin G-related protein peptide, and it is antagonist of CGRPP, and it reduces your migraine-free days, improves quality of life. So you can see here one analysis that has been done here. You can see here more than 2,000 patients were selected in case of episodic migraine. And as assessed by the proportion of patients with at least 50% reduction, you can see in the number of monthly free migraine days by 12 weeks. And it was given both in migraine aura and without aura, 45% for 70 mg, 45% for 70 mg was given, and rest 46% 140 mg was given, 32% where placebo was given, and without aura 37% for 70 mg, and 51% for 140 mg, and 25% for placebo. So you can see result here. There was no adverse effect, and it was very mild. These results support the use of Ernumab because we all know treating migraine is a very, very difficult thing, and this is a prophylaxis. Nusinersen, what this drug is. Important thing is, we all know basically what happens in case of spinal muscular atrophy. There is reduction of SMN1 protein that is basically dealt with SMN protein gene. What happens? There is a functional reduction in SMN gene. So what this drug does, nusinersen, what it does, it ameliorates the function of SMN2 gene. Normally, how people survive of spinal muscular atrophy? Because of SMN2 gene that produces lower, very few SMN protein, the survival motor neuron protein, and this SMN2 protein gets converted into SMN1. Then it increases the motor power. You can see here, the next is your drug Cenobamate. This is anti-seizure medication. You can see here the trial, uncontrolled focal seizure trial. It was done, it was published in Epilepsia. It a multi-center open. So high rates of retention and sustained reduction in seizure frequency were seen. The findings from the phase 2 study with a significant proportion of patients experiencing more than 90% and 100% reduction in seizure frequency for prolonged periods. So what happens? Many patients responded relatively early during the 12-week titration phase using the start low, go slow titration regimen. So treatment regimen were CNS related similar to the primary study. So findings suggest that Cenobamate is safe and effective during long-term treatment. IVIG we all have used in new onset refractory status epilepticus because we know that once this new onset neurology is there, it's difficult to treat. But it has been treated with IVIG. We get success sometimes, and very few role of IVIG, not in all status epilepticus cases. You can see here the conclusion is Oxford level 4 grade D evidence. So evidence is low. It's an unclear impact of IVIG therapy in adult refractory status epilepticus. So RAC cannot be recommended at this time, though it's being used because when there is refractory status epilepticus or SARE, super refractory status epilepticus, we don't have any drug left. So we are using IVIG, and to some extent we are getting results. Next drug is dapagliflozin. You all be aware of this drug because this is being used in diabetes mellitus type 2 and also in some cases this diabetes related CKD. So basically this is SGLT2 inhibitor, and it mitigates cerebrovascular cardiovascular risk. Now you can see here this trial, this improves cardiac hemodynamics and mitigates arrhythmogenesis in mitral regurgitation induced myocardial dysfunction. It was published in American Heart Association 2021, this one. So you can see here, it is effective in mitigating the cerebrovascular cardiovascular risk. The DAPA, you can see how it acts. It attenuates, it decreases cardiac fibrosis, and it also has effect on cardiac expression of apoptosis and endoplasmic reticulum stress-resistant proteins. So what was the conclusion? DAPA was able to suppress cardiac fibrosis and endoplasmic reticulum stress and improve hemodynamics in MR-induced HF rat, because this was done in rat. It demonstrates effect on the heart and its association with key molecular contributors in eliciting its cardioprotective function. So it can be safely used, dapagliflozin. Lemborexant, what is this? This is orexin antagonist. We all know treating insomnia is a very difficult task. We use a lot of drugs, but it was this trial was done and it was published, randomized clinical trial phase 3. It was published in Sleep Medicine in 2021 April. And the long-term effectiveness and safety of lemborexant adults with insomnia disorder, this was the trial. So what was the result? The highlights of the study were, because it's a recently approved treatment for adults with insomnia, so over 12 months, lemborexant was effective for all sleep parameters assessed, and it can give you benefits in adults with insomnia, but it will long-term. So LME5 and LME10 had significant effect on sleep onset and sleep maintenance. And you can see here, lemborexant effectiveness persisted at 12 months. It has to be used for a long duration. Now, this is a vesicular monoamine transport 2 inhibitor in hyperkinetic movement disorders. So what is the mechanism of action? It decreases neuropeptide at nerve terminal. That is your dopamine. It decreases the level of dopamine. So that's why it's acting in hyperkinetic movement disorders. Maybe this was published in Clinical Neuropharmacology, Real World Experience with VMA2 Inhibitors. What was the conclusion? The VMAT2 inhibitors are effective and safe in range of hyperkinetic movement disorders, but these are not readily accessible in the United States as not approved by the US FDA. Ofatumumab in relapsing remitting multiple sclerosis. This is what this drug is. Basically, this drug is fully human monoclonal antibody to CD20. What it does, how it acts, it prevents early activation of B lymphocytes. And this drug is also being used in case of chronic lymphoid leukemia, CLL. And at the same time, it has been used in multiple sclerosis also. So you can see here the trial with the mirror study was done. That was published in Neurology 2018 May. What was the conclusion? So that all subcutaneous, basically it is being given subcutaneously. Ofatumumab does demonstrate efficacy. Doses were most robust, more than 30 mg per 12 week, with a safety profile consistent with existing Ofatumumab data. So only partially depleted. So what happens? You can see here is showing the action, how it acts. So it depletes your early activation of B lymphocytes. So what was the evidence? The study provides class 1 evidence for patients with remitting multiple sclerosis, decreases the number of new MRI gadolinium enhancing lesions 12 weeks after treatment. So it's a good drug. Levodopa or carbidopa, it has been used, but this is intestinal disease in advanced Parkinson's disease. In 59 patients were used, 7 subjects, 20% died of, not related to this LCIG infusion, that is levodopa, carbidopa, intestinal infusion, and 11% discontinued therapy prior to the cutoff date. And this improved motor complications, and over 90% of patients reported improvement in their quality of life. That is a good thing, and autonomy and clinical. So what was the conclusion? It is effective for the long-term treatment of advanced Parkinson's disease patients and exert a positive and clinically significant effect on motor complications. It was published, and you can see here, into advanced Parkinson's disease, real-world experience was done, practical guidelines. So it can be safely used. And the important one, you might have seen the tenecteplase and all we are using for thrombolysis and alteplase. But you know the warning for all of us, efficacy and safety outcomes at alteplase in previous acute stroke trial. Now the not test 2 part, a trial found a trend towards an increased rate of symptomatic This is very warning is there, intra-ICH with use of 0.4 mg per kg of versus alteplase 0.9 mg per kg, tenecteplase 0.4 mg per kg. The tenecteplase group, what they found, the lower rate of favorable outcome and a significant higher mortality, although these results are not definitive. So what the result is, tenecteplase 0.4 mg per kg should not be used for intravenous thrombolysis. This is very, very important. So now stroke trials are testing the lower dose with 0.25 mg per kg. Now they are doing trials. And when to start the anticoagulants after intracranial hemorrhage, the American Heart Association, American Stroke Association published updated guidelines for the management of patient with spontaneous ICH. These guidelines say that up to 8 weeks after ICH for selected patient, it can be started. What about direct oral anticoagulants for cerebral venous thrombosis? So we are using warfarin, we are using this apixaban, DOAC and all everything. So now you can see here the Action CBT study that included 845 patients with CBT, corticovenous thrombosis. They were anticoagulated in 52% with warfarin, a direct oral anticoagulant in 33%, mostly apixaban was used, and the rest both at different times, 15%. So you can see here what was the result. The recurrent thrombosis was similar at approximately 1 year. However, the direct oral anticoagulant agent was associated with, it's a very, very important, lower risk of major hemorrhage, so it can be safely used. ARB blockers you might be, we are using all the times. So ARB can be used, and with incident Parkinson disease, a retrospective cohort study was done. You can see here, so what ARB is doing, it is decreasing the RAS, reduced brain RAS by ARB treatment, and an effective neuroprotective strategy for reducing Parkinson disease in patients with newly diagnosed hypertension. So ARB we are safely using in diabetic nephropathy. So here also in Parkinson disease, as it decreasing the RAS can be used, but still further clinical trials are awaited needed to confirm its neuroprotective effect. Now, combination of pharmacotherapy for painful diabetic neuropathy in a multi-central trial of 130 patients with painful diabetic, you can see here the amitriptyline has been used, pregabalin has been duloxetine. So they have mixed amitriptyline with pregabalin with amitriptyline and duloxetine. A 16-week follow-up combination strategy of pregabalin added to amitriptyline added to pregabalin, or pregabalin added to duloxetine, all provided greater benefit than monotherapy, and each strategy provided similar 50% pain reduction relative to baseline pain. So these results, what the combination pharmacotherapy is very effective compared to the monotherapy. No benefit for prophylactic anti-seizure medication in adults after resuscitation from cardiac arrest. You can see here the recent open label 172 patients were taken, had rhythmic and periodic EEG findings, and significant brain injury following resuscitation. They were having cardiac arrest following trauma. The poor neurological outcome, severe disability come out dead. At 3 months was not significantly different for those assigned to prophylactic anti-seizures. You can see here, when the standard compared with the standard care alone, 90% versus 92, approximately what was the finding? 80% of patients died by 3 months in both groups. So what these findings are suggestive of, anti-seizure medications do not reduce adverse neurological outcomes or death in patients resuscitated from cardiac arrest who have RPEEG, and support our current practice of not using prophylactic ASM. We have faced COVID, and also we must know what are the neural changes in brains of patients after COVID-19 infection. You can see here, changes in brain structure and functions after COVID-19 are the area for the investigations. MRI has been done. In 400 patients, one patient developed COVID-19 between one scan and the next at means of 5 months after infection. Again, the MRI was done. Those who had COVID-19, they had greater reduction in functional connectivity and structural measurements. Gray matter, what was the finding? Gray matter thickness in the orbitofrontal and parahippocampal cortices and global brain size compared with controls. So, despite mostly mild, that did not require. So, what are the additional data still needed to assess the persistence of this finding over the longer term and whether they have functional implications for patients with post-COVID? We can see here weaning strategy in medications overuse, headache. So we all are using. So what should be the weaning strategies? So in an open label trial, 726 patients with MAO just started with preventive medications and randomized to continue the overuse medications. You can see here by 9 to 12, headache frequency was lower in both groups, and similar for patients who continued the overuse medications and were switched to different medications. So what was the result? The result suggests that if you continue the overuse medication during the transition to effective preventive therapy for some patients, as long as there are no immediate concern for toxicity related to the overuse. So these were the findings. IVIG, all of you might have in CIDP, so who respond to initial treatment with intravenous immunoglobulin are typically transition. So 142 patients were taken with CIDP respond to. So normally how much dose we give? 2 gram per kg. So where they are thinking, so they have decreased the dose for 80% it was 0.5 gram per kg, and then a dose of 1 gram kg, and 92% for dose of 2 gram per kg. So adverse events were similar. So what you can see, you can lower the doses in the maintenance period, but if that lower doses are not responding to these doses, then you have to increase the doses. So thrombotic microangiopathy after gene thermotherapy, it has got the negative results. So there was severe thrombocytopenia and hemolysis. So further study is still needed. And we all see low risk of stroke with asymptomatic carotid arteriosclerosis has been done. So no need to do all those things like endarterectomy and other things. This is a very good study. So finding is consistent with other studies suggesting that the risk is patient with medically treated asymptomatic carotid is lower than the risk is surgically treated. So this is, and for patients 70 to 99%, so we imply intensive, so it should be avoided if the patient is asymptomatic. Then fenfluramine for seizure-associated Lennox, you can see here, though due to risk of cardiac valve injury and pulmonary hypertension, so it should be avoided. Now, oral formulation of edaravone for treatment of amyotrophic lateral sclerosis, the patient of AMS you might have seen, you can see here intravenous IV preparations are available 40 days, every 28 days. So it has been approved, and suspension may be given either orally or via feeding tube. So it improves, it's a very good drug, edaravone. Thank you.